Another myth that we hear is that choice is good, and one way to preserve the public healthcare system is to allow people who can afford to go into the private system to pay for their own surgeries and get them out of the long waiting line that might exist. Bob Evans, could you address why you'd say that that is a myth, that actually allowing people to buy privately is not going to help the public system?
Well, look at it from the physician's point of view, or whichever clinic you're talking about. You have here people who are paying privately and pay more than these people over here who are paying publicly or are being paid for publicly. The public prices are lower than the private prices. Which one do I look after? I mean, it's economic nonsense to suggest that income-motivated providers are going to be just as enthusiastic about looking after the people for whom they earn less money than for the people for whom they earn more money.
But what we hear is if there are 100 people on a wait list and 10 of them can go to the private surgery clinic, now there are only 90 people waiting for public health care. So what's the problem?
And at the private surgery clinic, they will get care from the same doctors. It would be different if doctors were not working on both sides of the street, but they are. That's the point. When you have a two-tier system, you steer patients who can afford to pay to the private side, and then you charge them more. I mean, the United Kingdom has demonstrated this ever since the introduction of the National Health Service in 1948, and it's normal economic behavior. You'd do the same thing unless you were sort of more of a charitably inclined. You say, well, I've got a group of people on this waiting list who have money, and they're willing to pay me, and I'm going to see them now, okay? And I'm not going to create new hours in the day from which I can now see these people privately and see patients as expeditiously on the public sector. There's a kind of a notion here that somehow if you privatize the part of the delivery system, doctors will appear from Mars.
Just to expand a little bit on that from a physician point of view, and certainly I have had the experience of referring a patient to an orthopedic surgeon who then tells them, you know, you can wait for 2 years in the public system, or I can do it next week for 15 grand. You know, that you get those kind of choices, which in Bob's world I think is, you know, sort of an idiot's choice. Which would you do if you had the 15 grand? But in fact, it's a much more complicated situation that we're confronted with both as physicians and as patients when you talk about taking 10 people out of one line and therefore shortening the other line and things can go ahead. In Canada, we do have a genuine shortage of healthcare workers, including nurses, doctors, etc. So when you do start to move significant numbers into a private system and incent them to do so, you actually take some of what's away from the public system. But it's actually even more complicated than that. In fact, it's very difficult to tease out all of the various factors that go into why this doesn't work. But it doesn't work. Because in Australia, where we have the wonderful natural experiment where they've gone this route ahead of us, it's very obvious that across Australia, the more private care is given, the more privatization occurs, the longer the public wait becomes. And there are many reasons for that that have to do with the quality of care. They have to do with cream skimming, where you take all the least problematic ones out of the top, where you do a little work with a golfer's knee. You know, my grandmother falls down, breaks her hip, has diabetes and hypertension. To complicate matters, they go into the public system. So there's a whole host of adaptations that occur within it to show that it doesn't work.
In Quebec, we tend to lead the way in terms of bad practices in funding, which I'm not very proud of. But there was that hospital, a big hospital in Montreal, where they had problem retaining nurses. Working conditions were so dreadful that nurses tend to work anywhere but in that hospital. So they had the doctor, they had the operating rooms, they had the patients, but they didn't have any nurses left. So they were not able to operate the patient. And there a private clinic went to see the hospital and say, hey, we have nurses, just send your doctor and your patient and we'll do the operation in the clinic. And the hospital signed the deal. So now what we're doing is we're paying more So we can build new operating rooms. We have brand new ones at the hospital that we're not using, but we're paying through our taxes, new operating room, plus profits for the private clinics. The doctors are operating there, they could be operating elsewhere. And the worst part is, where do you think the nurses come from? They have published ads in the newspaper looking for highly experienced nurses in the operating rooms. They're all coming from public hospitals. So now in other hospitals, you have nurse shortage even worse than what we had before.
And I guess my point from this is that there shouldn't be a social dilemma for us, because that might be a dilemma if we had to decide, well, maybe if people are making more money, they should be, etc. The point is, it doesn't work. Not only is it wrong, but it doesn't work. So I fail to see the dilemma in this. Why would you introduce a private care system which, as Britain has proved, leads to lower quality of care, that, as Australia has shown, leads to longer, not shorter, waiting lists?